and she specializes in palliative care, social work, as I do. And she's also an intern at the Smilow Cancer Center down at Yale in the palliative care program. And then we also have Amy DePaolo, and she is the Oncology palliative care social worker at Praxair Cancer Center. So thank you again for being with us tonight. And Susan, I'll let you take it away.
Okay, I'll share my screen. You tell me if everything looks good.
Looks good.
Okay, you can see in here? Okay, great. Thanks, Jacqueline. Hi, everybody. Like Jacqueline said, my name is Susan Godino. Just to tell you a little bit about myself before we get started. Like she said, I'm a soon-to-be graduating Master's of Social Work student at Sacred Heart University. Social work is such a broad field and so many things you can do with the degree. So the school really gives us a chance to give us a choice in how we're going to direct our studies. So anytime there was a choice to pick electives or certain research topics or paper topics, for me, it was medical social work and in particular palliative care, because that's where I knew I wanted to practice when I got out of school. And that's what brought me back to school at the age of 48, to be honest. So in addition to our coursework, we have our placements, both generalized and specialist year. Hold on, just. There we go. My generalist year, my first placement, I was very fortunate to be placed in a skilled nursing facility in Danbury. However, thanks to one of my professors at Sacred Heart, Dr. Suzanne Marmo, I was also a student researcher on a project that she had become involved with, and it was called Palliative Care Policy GPS. And it was a joint project between Yale Law School Solomon Center for Health Law and Policy and the Center to Advance Palliative Care. So this was more social work on kind of the macro level. And here's, oops, sorry, a screenshot of the finished product. It's a tracking tool to track legislation at the state level and also US territories, Indian Health Services, and Veterans Administration policy as it relates to palliative care. I know we're skipping a little bit ahead because this is more of a macro level, but just, bear with me. The goal of the site is to give visitors, most often are researchers or policymakers, but the general public as well, a way to analyze policy in palliative care, to look for trends, to investigate gaps, and really just to encourage policy development and innovation. It is kind of a cool site. It's very interactive. You can search your state, you can search by region, you can search by different facets of the policy, and there is the website in case anyone's interested. This is only the first stage of the project. My participation has ended with my generalist placement, but there are 2 more phases planned. One is to track regulation as it relates to palliative care, and one would be, the last one would be to track policy at the national level instead of the state level. This year, for my specialized placement, I have had the good fortune, like Jacqueline said, to be at Smilow Cancer Hospital at Yale New Haven Hospital. I'm placed in the palliative care outpatient clinic, which is headed by Dr. Dmitry Kishevnikov. Yale also has a palliative care service, and I've had some exposure to that as well. It's been a great experience personally, educationally, professionally. I will just say that I'm not here necessarily as an employee of Yale or as representative of Yale. I'm a student who has a interest in oncology and palliative social work. And honestly, I'm also here because I'm sharing information that I wish my own family had had years ago when we faced our own cancer journey. I know each family is different, each journey is different, but my hope is that there's maybe some information here that no matter where you're receiving your treatment, may be helpful. If there are any Smilow specific questions, I'll be happy to try to answer them. If it's out of my scope of practice or something I don't feel like I have the answer to with the tip of my fingers, I will absolutely get the information back to Jacqueline. So enough about me. What are our objectives for the next 25 or 30 minutes or so? To answer the questions, what is palliative care? What are the benefits of palliative care? Who provides it, and how can it be accessed? So the first question, what it is and maybe just as importantly, what it is not. I'm happy to have this opportunity to talk about this, because to know what palliative care is and how it can be beneficial is helpful, because sometimes there's confusion as to what it is, and that misunderstanding can sometimes bring up some anxiety or some worry if the word is introduced in the course of treatment. So this is a chance to maybe alleviate some of that worry ahead of time. The World Health Organization, the Centers for Medicare and Medicaid Services, and the Center to Advance Palliative Care, they each have their own specifically worded definitions as to what palliative care is, but they're all conveying the same basic idea, which is that it's specialized medical care that prevents and relieves suffering of patients with serious illness and their families through the management of symptoms and with the goal of improving the quality of life. In this context, we're talking about patients with cancer. However, it's appropriate for many diagnoses, ALS, heart disease, kidney disease, just to name a few. It's an extra layer of support in addition to the support you're getting from your medical team, your oncology team. And it has a holistic approach, a holistic philosophy. It addresses the needs of the whole person, not just as that applies to the disease itself. And it works to align the patient's medical care with their personal values and their goals. So if you have any familiarity with hospice, if you've had any experience with that in your family in the past, that may sound a little familiar to you. You know, hospice also has a holistic approach. It focuses on quality of life. The care unit is the patient and the family, and that's all true. But hospice care and the Medicare hospice benefit is appropriate for those who have incurable disease, whose life expectancy is very limited, 6 months or less, and who have made the decision to forego any further life-extending treatment. Whereas palliative care supports patients while they're receiving curative treatment or life-prolonging treatment for their disease. It's based on need, not the prognosis, and it can be delivered at any age or at any stage of the illness. So a way to think about it is, while all care that is delivered by hospices can be considered palliative care, not all palliative care is delivered by hospice programs. The setting for palliative care can be a hospital, an outpatient setting, a nursing home, or even patient's home. I'm a former math teacher, so I like to think of it in terms of almost like a set and subset. So if you look at the big circle, that's palliative care, the philosophy of palliative care, the type of care, symptom management, quality of life focus. And then the smaller subset would be hospice care that is appropriate for those people, like we said, with a limited life expectancy, 6 months or less, and who are no longer receiving treatment for their disease. There may be different names for this service. Some facilities have moved away from the term palliative for just this reason, because it can be confusing and cause some stress. I know Memorial Sloan Kettering, their palliative care is now under their supportive care program, but whatever the name, the referrals are made to specialists, palliative specialists, whenever symptom management is complex enough to warrant some more time, some more experience, or some more expertise than can be offered by the oncology team. So again, here's just kind of a graphic of the evolution of the paradigm of palliative care. This shift from the upper box, which is the dichotomous view, either the patient is receiving that curative care, or now it's time for comfort palliative care. Whereas the lower box, they can be happening concurrently, and that's the evolution. It's not always a straight line. It's not always an even linear progression like that, but it gives you a sense that these things are happening together. This evolution has been happening. Palliative care was formally recognized as a medical subspecialty in 2008 by the American Board of Medical Specialties. It's also recognized internationally. The specialists in this field receive in-depth training in pain and symptom management, communication surrounding goals of care, and coordination of care. And in addition to doctors and nurses being able to receive the specialty and the specialized training, There are also certificate programs specifically designed for social workers, chaplains, and pharmacists in palliative care. Okay, so that was more kind of a broad, definitional, macro issues, excuse me. Now let's kind of talk about on the personal level. The four kind of main buckets of service that will be addressed would be pain and symptom management, communication, kind of the extra services of emotional, psychological, spiritual support, again, focusing on that holistic view, and then practical or concrete assistance. Palliative care is usually delivered with an interdisciplinary model. So for example, at Yale, the teams are made up of a medical provider, so that could be a doctor or an advanced practice nurse, along with registered nurses, social worker, psychologist, a chaplain, and Yale even has an art therapist that works in their palliative care program. But not all teams have the same makeup from one site to another, and certainly not all patients will see every member of the team. It's really going to be tailored to the care needs for each person. So that first bucket of pain and symptom management, what initiates most palliative care referrals is the treatment of these common physical symptoms: pain, fatigue, loss of appetite, nausea, vomiting, oh, excuse me, shortness of breath, and sleep issues. So these naturally are going to be addressed by the physician or the APRN. They're trained in the safe use of medication to treat all of these symptoms, including the use of opioids to treat cancer pain. Understandably, these days, I think people have some apprehension when it comes to the use of opioids, or even possibly they may have a history of their own of substance use that now they're concerned that they're going to be treated with these medications for their disease. And the doctors can take the time to talk with the patients, the family, to answer the questions and review expectations. So what medications are going to be used? What are my options? How will they be adjusted if they're not meeting my needs? How will I be weaned off of them if I don't need them anymore? And what are some of the procedures? Even something as simple as, what are the procedures for refills? Is there anything special I need to know? All these questions will be answered so that they will know how the pain will be managed safely, so that they can be as pain-free as possible, and also live as actively and as engaged in their life as possible. Because again, quality of life is the focus here. So the first visit or so with a palliative care specialist, part of it may be, tell me a little bit about who you are as a person. Tell me about your family makeup. Do you have support around you? Do you have enough support around you? What do you do for a living? Or if you're retired, what did you do for your career? What brings you happiness and joy? And what are your goals for the future? What would you like to accomplish that you haven't accomplished so far? And a big one is also, how do you like to receive information? Because this could be different. Some people like to have all the details, every medication name, every dosage. They want to do their own research. And other people have more of a short-term need for knowledge, and that's fine. They're both different styles, but it's important to know so that the care that's given can be guided by the answer to all these questions and the answer to what are your goals. So a patient might say, and I've heard it said, excuse me, my granddaughter's getting married in 4 months, and I really want to be there comfortably, and I want to be able to enjoy the day. Or I coach my son's soccer team, and I want to be there as actively as I can be and play out the season. Or it could be as simple as I need to continue to work. That's a priority. Excuse me. The second bucket would be that communication. And again, it's focused on the whole person, and it goes beyond that initial visit, beyond those conversations. It's one of the hallmarks of palliative care. So beyond the doctor-patient communication, family meetings can be directed by the doctors or social workers. There could be difference of opinions among family members on how best to support their family member, or maybe what the next steps would be, treatment options, and bringing the family together to talk in one room or maybe on Zoom could help ease that tension. Sometimes the help is needed to facilitate conversation between the patient and their caregiver. There was a man who said, "I know I'm so lucky to have my wife. I love my wife so much. She's doing everything for me. The problem is I'm trying to hold on to my independence. And I know that what she's meaning to come across as care is really causing me some frustration." So having that conversation with someone and maybe brainstorming on how to have that conversation without hurting her feelings, but still getting his own needs across could be helpful. I should interject here that it's possible that some of this may have already been addressed by an oncology team. Very often patients have established a relationship with that team weeks, months, maybe even years before they receive a palliative care referral. And that collaboration between those teams will happen, specifically between maybe an oncology social worker who has a relationship with the patient and the palliative care social worker to support the patient overall. Because as one of the doctors at Yale in family meetings, when he's describing palliative care, he says that the goal of the oncology team and the oncologist, the reason they wake up in the morning is to fight that cancer. And the reason that the palliative care team gets up in the morning, the reason they come to work is to help the people through that process, through that journey, to support them as best they can. The palliative care team may be more likely to facilitate conversations around advanced care planning. If you're not familiar with what that is, I'm going to quote Diane Meyer, who's a leader in the field and is the former director of CAPC, that's Center to Advance Palliative Care. She says, "It's a process that addresses the possibility that at some point in your life, due to illness or injury, you will lose the ability to make your own decisions regarding your care. Advanced care planning provides a roadmap to those who would have to step up to make the decisions on your behalf, if and only if you are unable to make your own." She goes on to say, "It's important to note that as long as you are alert and cognitively intact enough to participate in decision-making, your plan would not be activated." So this could mean the designation of a healthcare representative, maybe even a primary and a secondary person, someone who would communicate your wishes in the event you are unable to speak for yourself, someone you trust, who knows you well, and who you feel would not only know your wishes, but honor your wishes. The completion of a living will would more specifically outline efforts you would or would not be made to prolong your life if your brain was permanently injured and there was no expectation of meaningful recovery. So these are really difficult things to think about. These are really difficult conversations to have. And they are made easier when they're guided by people who have the training and the experience to facilitate this type of communication. And beyond working with the patient and the family, the palliative care medical specialists can work with the oncology team to clarify questions the patient may have regarding their care, discuss potential benefits and side effects of possible treatment options, and if and when it's appropriate, they can also help transition to end-of-life care, so that other piece of palliative care that is hospice care. Sorry about that. Okay, so the third bucket would be psychological, emotional, and spiritual support. Things like reducing depression and anxiety and building coping skills. That can be the focus of social worker, psychologist, perhaps in the case of Yale, an art therapist, and they could use a number of modalities, talk therapy, cognitive behavioral therapy, meaning-centered therapy, or through expression in the case of the art therapy. The support can be offered to the patient as well as the family member who's going through their own stresses, their own change of roles perhaps, and their own balance of being a caregiver and other responsibilities in life. I don't think I have to give more details. I think you all understand that cancer affects the whole family and people around you, and everybody needs some support. And last but not least, what the chaplain would do is to explore some of that, maybe spiritual or existential distress that may be experienced. Illness can bring people closer to their faith traditions, maybe as how they were raised, or it could do the opposite and cause some doubt, ask some questioning, maybe why me, some big life questions. And the chaplain can facilitate those discussions. It is all non-denominational. It can be accessed whether or not you have any faith background at all. And to discuss these questions, maybe it's things like not giving up hope, but maybe seeing that you're hoping for something different and things are changing, but just guiding some of those big questions. And then there's the practical, concrete assistance that can be offered. Oftentimes treatment can mean the inability to work, and a palliative social worker can help you through the steps. And I heard there was a workshop already, but through the disability process, that can be tricky. And there may be grants and some financial funds available to cancer patients that, again, a social worker, if it hasn't been addressed already by the oncology team, can maybe facilitate applications and help with that. Or maybe reach out to some community resources, whether it be for transportation to appointments or other supports in the community. If you do any investigation into palliative care, if you do any reading or videos, very often you hear it described as a team sport. And this approach is very advantageous because there is interplay between the symptoms of the disease. Let's say, take a look at that orange section and the red section. A patient with anxiety may be experiencing their pain differently because of the depth of their anxiety. Depression can cause lack of appetite, lack of sleep, which is going to impact quality of life. It may also impact clear thinking to be a part of those decisions in a deep way. It can also impact relationships with caregivers, not surprisingly, and all these things can be addressed. When the specialists coordinate and share this information, the care is just deeper, and it can be done either through a formal, interdisciplinary team meeting that may happen on a weekly basis, or maybe just informal sharing among the group. Two examples I can think of this from my experience is, one where in a meeting with the doctor, a patient just happens to mention that they've suffered a recent loss. So that could be a call to a social worker or psychologist by the doctor and say, can you just check in on Mr. Jones? He happened to mention that he had a loss, and I just want to see if there's any extra support we can offer. He may not need it. He may feel like he's okay, but maybe just touch base with him. And on the inpatient side, early on in my internship, there was a man who was recently diagnosed with cancer. He was admitted to the hospital. His pain at that time was not controlled yet, and his anxiety was pretty high. He just wanted to go home, and everyone knew that wasn't possible, that his pain wasn't going to be able to be controlled at home at this point. So the palliative team kind of assembled. The APRN, the pharmacist worked together to find the right medication to get his pain and his anxiety under control. The social worker, including myself, were up there to support him and his wife, take his wife aside, tell her she was saying and doing all the right things. She was being strong but gentle, and just being there for her shoulder. And once this was everything, the pain was controlled, the anxiety was controlled, he was able to take that breath. He was able to have those conversations with his wife, able to meet with his doctors, and then plan next steps accordingly. And I think, before that was really all managed, that would have been a tough thing to do. The ideal timing of palliative care is something that's being studied. And again, it's not, always appropriate for every person. It's more for those complex cases. But there is some evidence base for early palliative care. This study by Dr. Temmel and her associates was published in 2010. It's an often cited study with patients with lung cancer. The patients who volunteered for the study were separated into two groups. One received standard care, and early palliative care. And the results of the studies did show an improvement in quality of life and a reduction in the depressive symptoms among the patients who received the standard and the palliative care together. And in fact, the World Health Organization, the American Society of Clinical Oncology, the American Cancer Society, and the Institute of Medicine all support the involvement of early palliative care. It's a growing field, which is great because thanks to technological advances in treatment of people with serious illness, people can live with diseases such as cancer almost in a chronic state, and the support that palliative care can offer is much needed. There is some variability to access across the country. In 2019, as you can see, again, that Center to Advance Palliative Care put out their state report card, and their analysis showed that there were three main factors contributing to whether or not palliative care is available: geography, tax status, and the size of the hospital. The Northeast and the mountain states have almost universal access to palliative care in hospitals, not so much the case in other parts of the country. A not-for-profit hospital is more likely to have palliative care, and the size of the hospital is also a determinant with, in 2019, 94% of hospitals with 300 beds or more having a palliative care team. Here in Connecticut, we fare pretty well. Connecticut, in fact, in all of its bordering states, received a grade of A, which is defined as 80% or more of the hospitals having a palliative care team, with Connecticut receiving a 95.8 specifically. So how is palliative care accessed? A medical referral is needed, but that's not to say there's not some room for self-advocacy. There are still some physicians who are not fully comfortable with for suggesting palliative care because they know that might cause some stress, or maybe they don't want to think of that yet, or they don't have an understanding even. It depends on the situation. So if you are aware of it for you or loved ones, and you think it's something that would be appropriate, it's something you may want to just ask your medical team about. Is it something that's available here? Is it something that you think might be appropriate for myself or my family member? It is covered by most insurances, but private insurance, as well as Medicare and Medicaid. And if you do get a consultation, CAPC has a list of recommended questions for that initial visit. And here's an example of some of them. So what can I expect from palliative care? Where will I receive my palliative care? In the hospital, home, nursing home? Who will be a part of my palliative care team? What are your recommendations for my care? What will you do if I experience severe pain or uncomfortable symptoms? How will you communicate with my other doctors? What decisions will my family or I need to make? Will you be able to help explain the issues involved in making these decisions? Will you communicate candidly about my illness with me and my family? What support will you provide to my family or caregivers? Will you still be involved in my care when I'm discharged from the hospital? Can you explain the difference between hospice and palliative care? Hopefully that's one that we've already covered. Will you still be available to me throughout my care, including hospice if need be? And what resources do you recommend for me to learn more about palliative care? That one I can actually help with. The Center to Advance Palliative Care, their kind of public website, not the clinical website necessarily, is getpalliativecare.org. It's an excellent resource for patients and families. There are videos, there are podcasts, webinars, provider directories, and also links to other supports that might be helpful. The second two refer more to that advanced care planning that I mentioned, Prepare for Your Care, and the Conversation Project. two excellent websites that just kind of start people on thinking about that process and maybe how to initiate conversations with loved ones or initiate conversations with their medical team and start to get that process in place if they feel like that's something they want to do. And just some references. And I thank you for listening. Like I said, this is something that I wish I had been more aware of years ago. And I hope that something that you heard tonight is something that is either helpful to you or maybe helpful to someone else in your life. Thanks a lot.
Thank you, Susan.
Just trying to stop sharing my screen. There we go.
Yeah, thank you. Thank you so much for that. And I want to just hand it over to Amy now. And then we'll end with the Q&A.
Try to share my screen. Give me a second. Can you see my screen? Yes.
Yeah, yep, it's
Okay.
there.
All right, good. Okay. So I want to first thank Ann's Place for asking me to do this. And Susan, that was wonderful overview. That really was, I think, very, very comprehensive. So great job on that. I want to just start by saying I obviously work at Danbury Hospital. So a lot of what I'm going to share is coming from that place of working at Danbury and Nuvance, because I am going to talk about how one accesses palliative care services, specifically within the Nuvance health system. However, based on my experience and talking with colleagues, it is similar kind of at other institutions, because I'm sure not all of you are coming to Danbury, but there are similarities if you're going to a different hospital system. And if you have questions that are not related to Danbury, I'm sure Ann's Place can connect you with the appropriate person to talk to if I'm not meeting those answers to those questions afterwards. And we do get a lot of questions here, even within the oncology department, about what is palliative care? What does that mean? How do I access services? So this is obviously an ongoing dialogue we have internally. So a little bit just about Nuvance Health palliative care services. And you're going to hear a little bit of overlap, obviously, in what Susan was saying, which is a good thing, because it should be universal when you hear about palliative care and what's being done across the board. Our palliative care team here is patient and family centered. The goal is to improve the quality of life for patients with chronic or life-limiting illness. And our palliative care team covers a whole variety of areas where they can provide assistance and care. A lot of what Susan mentioned is exactly what I have here. So they provide obviously pain and symptom management through the course of illness, coordination of care, and communication with patients, families, and the caregivers across the continuum of care. They can help navigate the healthcare system, emotional and spiritual support for patients and families, a lot of communication, both when a person is in the hospital and outside of the hospital. There's a lot of different people, on the person's healthcare team. So I sometimes find that palliative care can sometimes be that link that pulls it all together. They obviously can help improve the quality of life and comfort throughout the course of an illness. Obviously advanced care planning, and then if and when appropriate, referrals to hospice care. So here at Danbury and really across Nuvance Health, our palliative care team consists of physicians, advanced practice nurses, licensed clinical social workers, and spiritual care. That's the team itself. And as Susan mentioned, somebody might not see the whole team as, each individual person, or they may, and it really does depend on their needs. I will say the majority of the time, if palliative care is involved when somebody is in the hospital, they pretty much see everybody on the team. They're going to see and let me go back for a second. So our physicians and our APRNs are doing the same role. So they're either going to see a physician or an APRN on the palliative care team. So the patient then will see a social worker and they'll see spiritual care. It's kind of automatic if somebody is in the hospital, that they're going to have all those individuals who are involved in their care. The person can obviously decline, but I think here they really value making sure that all those needs are being met upfront, at least from an assessment standpoint.
Amy, if you could just move your slide, because I think we just are seeing the first page where it says overview, and I think you're probably on maybe your second or third.
Hold on. Hold on, I'm sorry.
Oh, that's okay.
Okay, I have 3 different screens up on my computer, so. So you're not seeing the slide at all?
It's
So
not moving.
Oh, that's weird. Okay, let me try again.
You may also, I don't know if you have it switched to slideshow, because if it's not on slideshow, sometimes it won't move on our end. So you may have to put the actual, at the top where it says slideshow.
Okay, I'm gonna try again.
Sure. 1 minute. Let's see.
Are you seeing anything now?
Now we see the first slide.
Do you see the second slide?
No.
No, it's not moving on our end.
Very odd. Okay, hold on. I don't want to take me off, but I'm going to try one thing.
Sure.
Sorry, everybody.
That's okay.
You see anything right now?
First slide. So maybe try, can you click to the second slide?
What do you see now?
All right,
Yep.
That's the first. You're on the slideshow. So try it now. I think it might work if you click forward. Yep.
Yep.
Okay, so you just can't see me right now.
Yeah.
Great. Okay. I'll go live in person afterwards.
Sure.
Sorry about that. I'm having
That's okay.
technical glitches. Okay, just give me a second. Okay, I was here. So you see the one that says palliative care team?
Yes.
Okay. So in terms of the team, as I mentioned, it's really the whole team as from an inpatient standpoint. From an outpatient standpoint, that might not necessarily be the case. I do find more when it's outpatient, it's a little bit more customized. So they're always going to have either the physician or the APRN who does that initial palliative care consult. And then based on that, the other members of the palliative care team will then follow up with the patient based on what that assessment determines. So for example, if social work is needed, then social work is going to come in. If spiritual care is needed, then spiritual care will follow up. And so obviously that brings up the next point, where can one access palliative care services within the New Advanced Health Network?
So obviously I mentioned inpatient, and Danbury and Norwalk hospitals have very similar models for the way palliative care is structured. I'm not going to go into the New York side unless somebody later has a specific question, just because our Danbury and Norwalk programs are so much, so similar. And we've had that relationship for a long time. We're really building on the New York relationship because that's a fairly new kind of merger. And then there's New Milford as well, which is a much smaller hospital, but they do offer palliative care as well. Then specifically at the cancer centers, we obviously have a palliative care presence, both at Danbury we have a new palliative care provider for just the cancer center here at Danbury and New Milford. So she's fully on board. She's an APRN. She's dedicated just to oncology, which is a really needed, obviously, area for us here. And then Norwalk has their own outpatient palliative care provider as well. The other interesting thing about our palliative care program, and I don't know if other palliative care programs do this, but our palliative care program is also available through our medical group, through our primary care offices in the community. So for our maybe non-oncology population, individuals can tap into palliative care resources if they're seeing their primary care. And I think that's just worth noting because you might know somebody who would benefit from palliative care who maybe doesn't realize they could talk to their primary care physician about that. Or if somebody is, ending their treatment and moving on to survivorship, but maybe down the road they have another need that comes up and they're now under the care of their primary care, they can follow up in terms of palliative care needs with their primary care physician. So I think it's a really good model that we're offering, and I think we'll keep expanding upon that as well. And Susan mentioned a little bit about this, but I think it's worth reiterating. Palliative care is appropriate, obviously, at any age or stage of a serious illness, not just end of life. But again, this really depends on the patient's needs and where they are. And we still do a lot of education, not just with the patients and families, but also with our staff, that palliative care does not mean hospice. It's not that, there's no more treatment. It is in conjunction with either curative treatment or life prolonging treatment. So there is a lot of education that we continue to do, but it is absolutely appropriate. And sometimes it's appropriate as early as we can get in, because we do find that the earlier we're helping individuals manage their symptoms, the better they will do through the course of their treatment. And obviously, you can see, and it's similar to what Susan was mentioning, why palliative care gets involved in terms of what symptoms they manage. And what we find too, that if we involve palliative care, particularly earlier on when it's a later stage cancer, patients tend to have a better outcome for a longer period of time, particularly in relation to managing those symptoms. So we have an initiative here to really get palliative care consults earlier on for those patients. And again, that's working with our oncologists in terms of making those referrals, communicating with the patients that palliative care is available. So how does one access palliative care? Well, again, we have those designated palliative care providers, but it is about letting our patients know we have those providers and who they are and what they need to do to access them. So first and foremost, it's really upon our physicians to refer to palliative care. But we also want to make it known that the patients can have those conversations with their providers as well. So if a provider for some reason didn't make a referral, it's certainly appropriate for a patient or a patient's family to ask about palliative care. Is it appropriate to make a palliative care referral for my mom or my sister or my husband, or for the patient to even say, I'm thinking, I'm really having trouble with these symptoms, or this is how I'm feeling. Could I see a palliative care provider? That's absolutely appropriate to ask those questions. And then, as we mentioned before, obviously inpatient palliative care is utilized very much throughout the hospital system and then our medical practices. I wanted to talk a little bit about kind of the precursor, what I would say, to maybe having palliative care involved. And this is a lot of sometimes what I talk to patients about. It's communicating with your physician and kind of having the knowledge or being a little bit more comfortable with some of the discussions to have, where you might then know, well, should palliative care be involved? What's going on with my cancer? Would it be helpful in terms of managing my symptoms? So I wanted to give some examples because it's really important early on, after you've received your diagnosis, so you understand kind of goals of treatment, prognosis, and options for managing symptoms. And I do often have patients who tell me, I'm not sure about my stage, or what is my prognosis, or what does that mean? Now, not everybody wants to know those things. I need to say that up front, and that's fine. And I think there's a place and importance to respect everybody's wishes and what they want to and what they don't want to know. But if you are somebody who wants a little bit more information and you're not sure how to ask that or who to ask that to, I wanted to provide some questions that you certainly can ask your provider, and it may open up the conversation to, is a palliative care referral appropriate for me? And our physicians here are certainly used to answering these types of questions, sometimes from patients, sometimes from family members. So the first are certainly questions to ask about your diagnosis. Obviously, what type of cancer do I have? Where is it located? What is the stage, and what does that mean? And then what is my prognosis? And those are questions really early on, right at the initial stage of diagnosis. And then next are the questions about their treatment. There's so many treatments, they're ever changing. It's a whole new world for people. It's all that medical jargon that gets kind of lost and fuzzy for everyone. But also very important for people to know, what are their options first and foremost, but also which treatments or combinations of treatments does the provider recommend and why? What's the goal of each treatment? Who's going to be part of their treatment team? I think this one sometimes gets overlooked, and it's probably one of the most important questions to ask because patients see so many different people, from the physician to our mid-level providers, which are APRNs or physician's assistants, to the primary nurse, to a nurse navigator, to a social worker, to our dietitian. That's a lot of people. And I think early on, if somebody knows who's part of their team, they might not remember everybody, but I think knowing, okay, I have a team of people around me who are going to help me, and how are they going to help me? I think sometimes can lessen some of that initial worry, anxiety about the things that they're going to have to potentially manage down the road. And then obviously how their treatment may affect their daily life. Similar to what Susan was saying, asking what's important to somebody is really important so they can best manage what the next steps are. Also, questions to ask about symptoms. What are common symptoms with the type of treatment somebody might get? How may the symptoms change during treatment and after the treatment as well? And then besides treating the cancer, what else can be done to relieve or manage the symptoms? Similar to symptoms, asking about treatment side effects. Very important to know the potential short and long-term side effects of treatment, ways to prepare. This is a big one, and I know our nurses go over this a lot, but there are many things somebody can do leading up to coming in for your treatment. Obviously, medications we give you during your treatment, but we want to educate a lot of people on what to do and what not to do in terms of managing some of those treatment-related side effects. And then if people develop a new symptom or side effect or something worsens, what should they do? What's the protocol to follow? Who to call? Is very, very important. And I think for all of these, especially the symptoms and the treatment side effects, to have another person hear this information, if possible, is really important as well. I always say 2 sets of ears are better than 1 if you can have another set. And then to ask about support, what type of support services does palliative care provide? And can your provider recommend someone who specializes in palliative care? And again, I went over obviously here what we do, but if you are going to another place and you're not familiar with the palliative care services, you can certainly ask those questions. Who's available? What does that look like? Are the supportive services available to only me as the patient or my family as well? Talking about the cost of treatment, things like transportation, practical concerns, who's going to help me with that? And then similar to what Susan and I won't go over all of these because they are, there's overlap, questions to ask your palliative care team, very important. Oh, I see there's a chat. Oh. So again, I wanted to just provide some general questions, and if Anne's Place wants me to share any of these, I'm happy to do that as well after the presentation, because I do think it's helpful to go into your appointments with some, questions to be prepared when you see your providers. And that's it. We can open it up to questions.
Thank you, Amy. And yeah, I would, if you could get us a copy of that last page, I think that would be wonderful, and we can get it out to everybody that's here tonight.